I would say that one of the most exciting things that came out of last year's ASCO was work on anti-PD-1 therapy and an agent called nivolumab that I know, Mary, you've had a lot of experience in working with. I don't know if you have as well, Nate, but it was really interesting work, and we did get an update this year that just really showed that these could be very durable responses. Did hear a bit about toxicity concerns, and I know, Mary, you've got some direct experience with that, and I'll ask you to elaborate. But there was a bit of new information that, first of all, with nivolumab, the benefits seem to be about equal now between the adeno patients and the squamous patients. And we've also got a new agent that was presented at our oral session, and I think there was a lot of enthusiasm around, which is an anti-PD-L1, or the ligand to the programmed death receptor. And Dr. David Spiegel presented on this new agent in not a large number of patients, but Nate, tell us a bit about that presentation and what did you think of it?
Yeah, I think this is rightfully one of the most promising fields about which people feel the most enthusiastic. Even though all of these trials, we have to keep in mind, are all still sort of phase 1 trials with 50 patients here and 30 patients there. But if you've got a real signal, you can see it with a relatively small number of people. So the two different ways to go at this are you can target the receptor, PD-L1, which is on white blood cells or lymphocytes, or you can go after the ligand, or PD-L1, which is on the target, which is, in this case, cancer.
So just to clarify, it's PD-1 on the tumor, on the T cells of the patient, and
right.
PD-L1 on the tumor.
On the tumor, right. And of course, it's more complex than that, but that's the idea behind the targeted effect in cancer cells. And basically what this does is PD-L1 is what cancer cells use to turn off the immune system so that it doesn't attack them. Okay? So if you block that, essentially they're defenseless and now the immune system can attack them, and that's the idea. You can allow the patient's immune system to actually take care of the tumor on its own. And in the PD-L1, we saw a very similar, I would say, activity to what was seen in the PD-1. Okay? About 22% of tumors, mixture of squamous cell and adenocarcinomas, had very impressive responses. So it clearly didn't work in everyone. I say 22% is probably an underestimation because they also have these delayed responses, which I think is very interesting, and it's going to be tough in the clinic potentially to manage this. There are some patients who have what looks very much like progression of disease, but in fact it's just an inflammatory response to the tumors that makes it look bigger on the scan.
But it seems to be real.
But it seems to be real. It seems to be real, and then later on they respond. So it may be a bigger than 22%, but what I'm most impressed by are two things. One, the duration of the response. So on this trial, of the 22% of the 50 patients on the trial who responded, every single one of them is still responding, some of them a year or more out. And two, I hesitate to make too many judgments comparing a 50-patient trial to a 30-patient trial, but the toxicities may be a little bit better using the PD-L1 than the PD-1. For example, pneumonitis or inflammation in the lungs is something that we always worry about in our lung cancer patients because they tend to have poor lungs to begin with often. There were no clinically significant episodes of pneumonitis seen in this trial. So that's one thing to point out. Now, Mary, you have a lot more experience dealing with these drugs than I do. I don't know if you have noticed any differences between the PD-L1 and the PD-1 drugs?
I think our overall experience is that PD-L1 seems to be a little bit better tolerated with the small number of patients that we've seen on that agent. Both classes of drugs seem to potentially result in very meaningful responses for patients that are prolonged. I mean, I think that's one of the beauties of it. And one of the things that we've seen also is that even if patients do develop an immune-related toxicity and require treatment with immunosuppressive drugs like steroids, that patients can still continue to respond even once they've been taken off the study drug. Right. And that's pretty amazing. I do feel that these drugs, it's not like chemotherapy where we know exactly what the potential toxicities are and we can explain those easily to a patient. If you have a fever, call. If you have nausea, call. With these drugs, the toxicity can affect any aspect of the immune system. And so to try to explain all the potential things that could happen in a way that a patient would know, oh, I really need to contact my doctor immediately can be a challenge.
Right.
And I think the way we do it is just very close follow-up. But I do wonder when these drugs, if they are approved and get into wide circulation and maybe don't have the potential to follow patients as closely as on a clinical trial, it could be an issue.
Mm-hmm. And the other thing about the trial that was very exciting is we have a potential biomarker that actually can guide us to who might most benefit from these drugs. So in the anti-PD-1 study that we heard about last year, looking at PD-L1 on the tumor seemed to be able to differentiate people who were more likely to respond versus people who didn't have much of a chance of response. And that held true to some extent in this time as well. The people who expressed PD-L1 on their tumors had a higher response rate. It wasn't everyone, but it was about 80% of those who expressed it had a response. Interestingly, some of the people who didn't have expression of PD-L1 also had a response rate, which is not what we saw in the PD-1 trial.
Well, we're kind of used to thinking about this with EGFR, where
Right.
you've got one group that seems to be especially likely to have a strong benefit, but that doesn't mean that you shouldn't try with the other
Right.
group and you might have some success.
Right, and we know that, when you do a biopsy of a tumor that's this big and you get a piece that's this big, you're making your judgment based on that tiny little piece. You don't know that you're actually seeing what's going on in the entire tumor. And the assay of this immunohistochemical stain, it may not be a perfect assay. So it's nice to be able to develop that, and I hope that that's developed further. I'm sure it will be. But for now, I don't know that trials that exclude, and I think some of these trials may be actually only going forward in people who are expressing PD-L1. I'm not sure if that's the right choice.
I think it varies from one company and one agent to another, but I think there is a lot of open question and controversy about whether that's really the right way to go. Mary, what are your general impressions after using these agents for a couple of years now in terms of toxicity concerns for you and the patients and the range of patients and the durability? What do you think?
Yeah, I mean, the nice thing is I've seen patients with squamous cell respond, I've seen patients with adenocarcinoma respond, I've seen patients with different mutation profiles respond in later lines. Some of our patients on the initial PD-1 trial were really far along in the course of their disease, third-line therapy, and still responded very nicely. And I feel like patients sort of fall into two categories. Either they have no toxicity and they can't believe that they're on a drug that doesn't cause anything, there's no nausea, they don't lose their hair, or they get these unusual immune-mediated toxicities. And I think as long as they're recognized early, we've had a lot of success with treating those and having the patient get back to normal. But it is a little bit concerning that you don't know what organ might be affected, and the symptoms can be very subtle.
And we'll need to gain experience with this as time goes by. Interestingly, also, I've just heard of a few parenthetic reports of remarkable responses in some difficult patients like spindle cell and sarcomatoid, where these are rare subgroups, and the little we have known about them is that they don't do well with anything else that we've had, and sometimes we've seen remarkable responses in these patients who are notoriously hard to treat.
Yeah.